Assalamu alaikum. Thank you, Doctor, for the introduction. Just a minor correction. I was at Prince Sultan Military Medical City, but now I'm in SMC directing the department in Riyadh. I'd like to thank the two previous speakers for enlightening us and for the Dr. Hanan Reyes, who invited me to give this talk. I am so fascinated that we have one full session for the extra-articular manifestation of rheumatic disease. The correlation between dermatological findings, ocular findings, and cancer is definitely something that all rheumatologists should be aware of, and us as physicians should always keep it in mind. So I have no financial disclosures, and I want to ask you, do you know how much an eye would tell us about what's going on back then? The eye is like the keyhole where you sneak in and you see almost everything. How much involvement could there be? Whatever happens in the connective tissue diseases, rheumatic diseases, vasculitis is all involved in this tiny organ, your eye. The ophthalmic eye, or the eye anatomy, is composed of three chambers, 3 layers of connective tissue, and it has 3 fluids. The eye has its own immune system. The anterior chamber, or let's see here, the highlighting is the sclera. This is when the inflammation happens in the sclera and the episclera. Inflammation confined to the anterior chamber, that is between the cornea and the lens, is called anterior uveitis. When the inflammation goes back to the vitreous, it is called intermediate uveitis. And if it involves any part of the retina, whether blood vessels, nerve fiber layer, or optic nerve, it is called posterior uveitis. And then we have something called panuveitis, when the whole eye is inflamed. The American uveitis classification has given us this important uniform language that we all speak the same. When I tell you my patient has panuveitis, you will understand that the patient has inflammation of the whole tissue of the globe. And when I tell you it is only anterior, you understand that the back of the eye is quiet. An ophthalmologist does not stop at the eye. Actually, the last thing we see is the eye. We look to the patient and see, before coming into our uveitis clinic, what is going on with this. We look to the gaze, we look to the posture, we look to the color, and we look to the deformities that the patient has. Some things are very frank, and some things you need to ask for, unveil a covered patient, or even take a closer look after you put your stain and see what's going on in the patient's eye. And I'm pretty sure you all have had a visit to the ophthalmology where you were told, well, you probably have dry eyes. And this is a very broad name that can be applied, and it's a big umbrella that has too many faults. So how can an ophthalmologist help a rheumatologist? Our sophisticated diagnostics are very updated. We can take pictures and directly send it to each other, and even share it with our colleagues. And the picture may be even histological without a biopsy. This is an optical coherent tomography that shows cuts in the cornea. And at the bottom here, in the bottom picture, you will see there is a small piece of white blood cell that is stagnating on the cornea. And on top of it, you see the dust there between the chamber and the iris. This is called anterior uveitis. We can also do the same to the back of the eye, and this is doing OCT for the retina. I can see the layers and if there are any infiltrations or vascular occlusion. And this is a new standard test. This is called OCT angiography. This is non-invasive. I can see the microvessels and what's going on there without putting a single drop of dye in the patient's vein. And it can even show more details than what we can see with fluorescein angiography or indocyanine angiography. The bottom left picture shows retinal autofluorescence, which is another non-invasive test, and infrared light is used just to see if there are any depositions and if they are active or inactive. So without ophthalmology, you will lack a significant clue to what's going on with the patient. The latest is the FLAIR photometer, and this is a device that measures the amount of protein in the aqueous chamber. So even if we don't have significant inflammation, that is white blood cells moving on, we can still see the proteinaceous material and calculate it and measure it and quantify it. Ocular symptoms are usually vague. Every patient may come with undefined redness, foreign body sensation, blurring of vision, and photophobia. And the differential diagnosis is huge. They are all the same, and you need to dig in like a detective. Take a look at this patient. He is 72 years old. He's been having chronic photophobia for severe lid irritation and severe dry eyes. The patient is known to have systemic lupus, and he is on Plaquenil. He was diagnosed as dry eye and received topical lubricants, but he was never happy. And you can see how frequently he was blinking. Fortunately, we have something called a tear check, where we can evert the lids and look to the meibomian glands. Now, just to remind you, your tears are composed of two components, fluids and oils. The meibomian glands that are placed on your lids are supposed to be the one secreting the lipid layer, and it sandwiches the tear film. If it is clogged, and just to let you understand, whatever is purple is active, whatever is black is occluded. So this patient had significant, here, let me go back, significant loss. It was 46% in the upper lids, almost 70% in the other eye, and the lower lids had minimal changes. How did I help them? Just to let you know that patients with systemic SLE and on Plaquenil have an additional drug-induced dry eye and may be subjected to more sophisticated treatment other than lubricants. Before going there, I'll show you this lady with Sjogren's syndrome, and you can see here in the video how badly her eyes are stained with fluorescent. This lady could not open her eye. My assistant was there, despite putting a lot of topical anesthetic. I have placed a punctal plug, and yet the patient did not improve. She had positive SSA and SSB, and you can see how damaged her meibomiography, how damaged it is. Only after starting systemic treatment with pilocarpine, this lady was no longer photophobic and was improving from debilitated, disabled lady to at least functioning and going out with her family. And this is her fluorescein staining went down to 1+. Now, Sjogren's syndrome is a chronic disorder, and it affects all the exocrine glands, so it's a systemic problem. We do not diagnose Sjogren in the clinic immediately unless we go into a survey and ask the patient specifically, and you all know how to do that. But the key, Mark, I think, the key question for us as an ophthalmologist is if they have xerostomia or signs of xerostomia. We make sure the patient does not have another mimicking factor like hepatitis C or had neck radiation or has sarcoidosis. The grading system is important for publication, but in the clinic, I think it's a little overwhelming. However, for your information, we do the Schirmer test in every patient and see if it reaches 5 millimeter or less. We also do the corneal staining grading. Lip biopsies are done by oral surgeons just to see if there is lymphocytic infiltration. And the Keuschel-Mason scoring should indicate that there is at least one foci beside a normal gland in a 4 millimeter biopsy. The increased risk of B-cell lymphoma with Sjogren type 1 is essential to know because you need to inform the patient and follow up with the rheumatologist and with the medicine for that. What else can we do to improve patient's life? Now, I want to make sure that the patient makes use of the minimal tear they have. We don't lose the tears we are giving. That's why we place a punctal plug. We have to improve the quality of the tears. So we ask the patient to wear warm compresses to improve the secretion of the meibomian glands. We use serum BSS, but in here it is tricky because we extract blood and we use the serum. If we use the same patient's serum, we are increasing the inflammation. We need to take it from a donor, like a family member, who is immune stable, and we can do that because it's sterile. We have to use topical steroids, cyclosporin, Restasis. Lifitegrast is not in Saudi Arabia, but it is also very helpful, and tacrolimus 0.3%. The lifestyle modification, I always tell my patients to stay away from any air currents, avoid makeup inside the eye, and frequent blinking exercise. That's when I ask them to squeeze their eyes 20 times after warm compresses. These are the other tools that we have, the intense pulse laser. This is like the DPL used in dermatology for rosacea, and the LipiFlow. And this is a direct massage on the meibomian glands that helps milk the meibomian gland. And eventually at the clinic, I can do this. I'm sorry if it is not so pretty for others, but we express the meibomian glands manually to make sure that the patient has sufficient and active meibomian gland secretions. Now, just to distinguish between them, dry eye is a broad spectrum diagnosis where Sjogren's syndrome actually lies underneath. The only difference between them is that Sjogren's syndrome needs immunosuppressive medication systemically, while dry eyes may improve only on topical immunosuppressants. What else in the eye can be affected? The skin. We can see the patient here with ectropia in systemic sclerosis, telangiectasia in skin rosacea, hypopigmentation or poliosis in vitiligo. The conjunctiva may come with ciliary injection, nodular episcleritis, diffuse episcleritis, and scleritis. Now the top three are very benign, but the bottom one is malignant. Episcleritis and scleritis can happen in any kind of rheumatic diseases, and they have 50% chance association with systemic disorder, which means there are 50% idiopathic. Episcleritis is a benign inflammation. It has mild symptoms and is often self-limited, and it is more common in Crohn's disease than it is with ulcerative colitis. Scleritis, on the other hand, has a higher patient autoantibody positive rheumatoid arthritis will have higher risk of developing scleritis, and unfortunately, if they do, this is a marker for mortality. The association between scleritis and rheumatoid arthritis together with positive ANA and positive rheumatoid factor is a high risk for mortality. Scleritis is blinding disease, and it has to be addressed immediately. It may precede systemic presentation by 9 years, and it can be even silent in patients with rheumatologic diseases. It can happen in polyarthritis, in relapsing polychondritis, Wegener's, inflammatory bowel disease, and in rheumatoid arthritis. This is a patient of mine I was managing in a military hospital with ankylosing spondylitis. Despite being on maybe 3 or 4 biologic medications, he still developed scleromalacia, and you can see here the bluish hue on the sclera. And he did develop a minor trauma with eye perforation that took us 3 hours just to mend this hole and close it. This is a patient that came to me just 2 weeks ago. He is known to have Crohn's disease, and he's been home depressed because of his embarrassing red eyes. He was socially deprived. His eyes were completely disabling him from doing any social function. He took steroids, he did not improve, he actually developed glaucoma, and the only thing that improved was the photophobia. Only after giving 1 week of tacrolimus, he came back very happy, and he allowed me to take a picture, and he said, please go ahead and present my case, I don't mind. The cornea. Now, the cornea is the most precious tissue in the eye. It is avascular, it is transparent, it is delicate refractive, so any change in the cornea will cause visual disruption. It is sandwiched between the tears anteriorly and the aqueous behind it. It is sensitive to electrolyte imbalance. It has its own immune reaction, and it has its own immune defenses. It is very unique, anatomically connected to the sclera at the side and on top of the iris or the ciliary body right underneath it. So the cornea shows what others cannot see. We have an entity called PUK, or peripheral ulcerative keratitis, and this is called serpiginous ulcer. Why? It circumferentially rotates around the eye, and it's like a belt. It erodes the side of the cornea and eventually ends into milking. The limbus is the anatomical structure where the connection happens. The blood vessels of the conjunctiva does not cross the limbus. They reach and then they loop around and they go back in a U-turn. This movement of the blood vessels at this unique spot makes the aggregation of immune reaction highly concentrated at this point of the cornea. Any inflammatory response at the eye will be shown directly in here. So patients with polyarthritis, look at me here, look to the differential diagnosis, what we have. Everything, almost everything, can cause PUK, rheumatoid arthritis, polyarthritis nodosa, Wegener's granulomatosis, the collagen vascular disorders as a whole, SLE, relapsing polychondritis, systemic sclerosis, giant cell arteritis, inflammatory bowel disease, Sjogren's syndrome, and even leukemia. So the differential is wide because this immune site is very active. This is how it looks like with Wegener's, and on the other side is polyarthritis nodosa. And you can see they are too similar. So as an ophthalmologist, I only have a differential. I have a sight-threatening condition, which I need a rheumatologist to help us find the diagnosis or the underlying cause. The cornea, on the other hand, has an anterior surface and a back surface. And I'm pretty sure you have seen kids with juvenile rheumatoid arthritis who has a white cornea, and you wonder what's going on. This is a band keratopathy where the calcium is deposited in front of the front part of the cornea because of chronic inflammation and imbalance of bicarbonate concentration. The back of the cornea has the precipitation of the active white blood cells, and this is the KPs, what we call our KPs. KPs can be granulomatous, and when I tell you that I have a granulomatous inflammation in the anterior chamber, you keep these things in your mind. It's either syphilis, TB, sarcoidosis, multiple sclerosis, and VKH. These are the commonest causes for granulomatous uveitis. The non-granulomatous uveitis will come with something called anterior chamber cells, hypopyon, and flare. You can see here in the video on the right side how there are cells floating behind the cornea in front of the pupil, and this is exactly what I see. I see the inflammation active in the eye. This is an OCT demonstrating how the white blood cells are stagnating in this anterior chamber. Fibrinous reaction or fibrinous membrane is another cause that tells me there is subtle inflammation. And this is very common in JIA, juvenile rheumatoid arthritis. Patients have chronic inflammation, and the ophthalmologist might overlook it. They don't know, they miss seeing the flare. Flare means oozing proteins from active inflammation. And it's a very strong indicator for activity. It means that the eye is not silent. In these cases, I do not need to use steroids. I can use non-steroidal anti-inflammatory eye drops. So when should a rheumatologist refer to an ophthalmologist? The incidence of extra-articular manifestation in axial spondyloarthropathy, this is, I think, one of the strong studies that a rheumatologist should know. It was published in 2021 from Sweden. It was a cohort of 3 different institutes that compared ankylosing spondylitis and differentiated spondyloarthropathy and psoriatic arthritis, and they were looking for the extra-articular manifestation of this inflammation. And guess what? They have found that ankylosing spondylitis is the winner. Most of the patients, like 20%, will have anterior uveitis, 6% will have irritable bowel disease, and only 2% will have psoriatic or skin manifestation. Psoriatic arthritis, on the other hand, was the loser. Almost very quiet, very silent inflammation. Undifferentiated spondyloarthropathy comes in between. So here, we need to know that males are more affected than females in ankylosing spondylitis, and the manifestations can vary from mild to severe. On the other hand, when should an ophthalmologist refer to a rheumatologist? And this is something that I always teach to my residents. Now, old days when I was a resident, we were trained and told that you don't have to refer a patient with anterior uveitis from the first attack, just wait, and if they have another attack, you might think of it, because it can be non-inflammatory. But then came the answer from the prevalence of spondyloarthropathy in acute anterior uveitis, and this was published in Spain. This is the Sentinel study, and it's very important. It resulted that 50% of the patients, I think there were 600 patients or 780 patients, 50% had axial spondyloarthropathy, developed it at some stage. 17% developed peripheral spondyloarthropathy, and of all of these, most of them had HLA-B27. However, the problem was not with those who have HLA-B27, because it's easy. If I do the investigation, the patient will go and he will be consulted, and they will have rheumatic follow-up. But the problem was with those who are HLA-B negative. I'm almost out of time. 2 minutes. Okay, the Dublin classification is very important, and it tells us that any patient with back pain below the age of 45 should be addressed and consulted and sent to a rheumatologist. Now, let me see here. What should we use for anti-inflammatory drugs? We prefer to use the DMARDs, then the T-cell inhibitors, and last will be the biologics. Just for your information, we ophthalmologists have found that anti-IL-17 is not the best choice, so secukinumab should be avoided in patients with anterior uveitis because it can increase the inflammation. Okay, I want just to highlight that the last disease, if we go into the collaboration between ophthalmologist and a rheumatologist, and here, allow me to jump here, sorry. This is a patient with Behçet's disease who was treated and given biologics. Sorry, he was given infliximab, and he improved significantly. However, however, even after infliximab, he did not reach 20/20. I just want to show you that the OCT angio will show us the areas of non-perfusion that contribute to the poor vision. And here is another case that is of interest. Patient with Behçet's disease had previous history of lymphoma. We could not give infliximab. The rheumatologist and I decided to give him Actemra, and he improved dramatically, and this was published in the Saudi Journal of Ophthalmology. Last but not least, patient with giant cell arteritis. This is a 58-year-old patient who came. I could not know what's going on with her. All of her investigations were normal. You can see the active arteritis that she has. Eventually, her only positive sign was high ESR. We gave her Actemra, and she improved dramatically and quietened and maintained her vision. So I don't know if you are aware of the VKH syndrome, which is something that is often missed and not diagnosed properly, but VKH is often missed as meningitis when it's in a acute phase, and they can come with poor vision. Eventually, we have sunset glow, and it's a blinding disease. It's a disease of children that can happen in as young as 5 years old. It's a disease for females mainly, and it can be treated strongly with CellCept. Lastly, I think that the collaboration between ophthalmology and rheumatology is essential. The patient has to stay with an ophthalmologist for almost forever, and there should be a preclinical ophthalmic examination before starting any medication. Thank you very much.